and welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Cardiology. I'm Dr. Seth Bilazarian, a cardiologist with PMA, and I'm here joined by my associate, Dr. Benjamin Conway, who's going to talk to us about blood thinners, specifically 3 commonly used blood thinners: aspirin, Plavix, and warfarin or Coumadin, and take us through what they're about and what they mean and how we use them. Dr. Conway.
Yeah, thanks, Seth. So there are a lot of blood thinners out there, and I just want to sort of define what I mean by blood thinner. This is not an official medical term at all, but it's a term that we use very frequently with patients because it's appealing in an intuitive way. We mean blood thinner the way that when you talk about paint thinner, you're talking about something that just basically makes the paint break up more easily and less likely to harden and that kind of thing. So what a blood thinner is something that reduces the body's tendency to form clots. And so it's, again, when doctors are talking to one another, we're usually not saying blood thinners, but it's a term that we use all the time with patients. And the important thing is that, remember, the clotting system is there for your protection in general, and it's supposed to protect you from bleeding when you're not supposed to. And so generally all of these drugs have the flip side risk of, while they may reduce inappropriate clots, they also may increase the risk of bleeding, and we'll get into that a lot more. There are a lot of ways that this conversation could go. We could all talk about the ones that are intravenous and the ones that you use in the hospital and heparin and all of these alternatives to that. But really, I think I'm organizing this mainly about the pill form ones: aspirin, Plavix, or clopidogrel, and Coumadin, or warfarin. And the reason is because I'm hoping that the viewer is going to look at their medicine cabinet again in a new light and think, oh, I'm on this medicine. Oh, this is why I'm on this medicine. And oh, this is why the doctor changed me from this medicine to that medicine. And so I'm just hoping that people will maybe get a better sense of the rationale behind the things that we choose. We're not expecting patients to prescribe their own IV blood thinners or even their own oral blood thinners. So we're going to be talking about aspirin, Plavix, and Coumadin. Aspirin was actually covered in a previous edition of Matters of the Heart for an entire half an hour, and so this is a bit of a whirlwind tour as well. So if you wanted to see more, you could always look for that episode. Plavix is, I guess you could say, similar to aspirin in that they're both in a very similar drug class as antiplatelet agents. And that means that they work on the cell-mediated clotting in the blood. And then Coumadin is another pill that really doesn't work on the cell clotting as much as the free proteins that are floating around the blood that participate in clotting. So before getting into the individual drugs, I just want to talk about the clotting system in general. So again, it's there for you. If I walk out of the television studio today and I get attacked by a cheetah, and I end up getting gored by that, I'm very glad that my clotting system is there to protect me until I can get to the hospital. But what happens is that there's also clots that form in the body inappropriately. And blood thinners are, of course, aimed toward limiting those. So, for instance, patients who have a disease called atrial fibrillation, which is an extremely common heart arrhythmia, have an increased risk of developing clots inside the chambers of the heart. When we put people on various blood thinners, our goal is to reduce or slowly dissolve those clots, or to just decrease the chance of them developing in the first place. And another thing that's near and dear, especially to Dr. Bilazarian here, who's an interventional cardiologist, is that clots are an important step in the development of heart attack. So you think of heart attack as being a cholesterol kind of thing, but really what's happening is a blister of cholesterol in the wall of the artery is rupturing, and it's leaking this gruely fatty lipid into the artery itself, and the first responders on the scene are platelets. They are zooming by in the bloodstream. They're seeing what's essentially a foreign body in the blood. They see this fat, and they jump on, and there's this big gang tackle of clot that develops on top of it. And so this is when Dr. Bilazarian has to go and do something about that. But an important medical part, an important medicine part of that acute coronary syndrome of plaque rupture is antiplatelet agents. And this is why aspirin is why you're probably hearing that if you have chest pain on the way to the hospital, you might want to pop an aspirin in your mouth and chew an aspirin, in fact. So clotting is an important part of an important source of disease, especially in cardiology. Again, they can block arteries, like they do sometimes in the legs, which is another thing that Dr. Bilazarian works on to fix. They can develop in the veins, and sometimes they can break loose and go up to lungs and cause problems like pulmonary embolism. They can form in the chambers of the heart, and they can form in the heart arteries themselves, among other places. And the other thing is that when patients have artificial heart valves, or sometimes other kinds of hardware that's been put near their bloodstream, clots can form there too, like on heart valves. And that's usually why people who get mechanical heart valves made out of stainless steel or carbon fiber or a foreign body, a foreign substance, usually require some sort of blood thinner. So again, the way clotting works is sort of like when you see some huge gang tackle in a football game. Some guy's running down the field with the ball, and usually there's one guy who gets a hold of him enough to slow it down. And just in the process of doing that, then before you know it, there's about 10 people piled on top of the guy with the ball. And the idea is that, that as that first platelet or that first clotting protein grabs on, it is essentially activating in a very amplifying way all of these other proteins and cells that are going by, and before you know it, bang, this big clot has developed. So there's a real explosion in some ways of clotting that happens. And it is sort of like, and the other thing is, of course, that once the whistle blows, it takes a while for all those guys to peel off one another and find the guy smushed at the bottom on the field. And it takes a while for at least the kind of blood thinners we're talking about for clots to actually go away, and they don't just disappear immediately. The clotting system also has redundancy built into it. So in other words, there are numerous pathways, both cell-based and there are protein-based, and they all pretty much do the same thing. But again, some work in areas of tissue, so platelets are on the scene first when you get injured or cut yourself, whereas clotting proteins might be on the scene first. So it's sort of like different branches of the military. You know, they're all on the same team, but at the same time, if something's happening in the water, it's usually the Navy that's going to get there, and if it's happening in the air, it's probably the Air Force. So, but they're all sort of working in concert. So we talk about blood thinners as a group, but really there are a couple of different categories of blood thinners, and I just wanted to break it down into antiplatelet agents, which are aspirin and Plavix, and then also these more clotting factor, blood protein oriented ways, like Coumadin. So let's just get into the antiplatelet drugs for a sec. There are a lot of different antiplatelet drugs, and if one of the two main ones isn't working for a patient, we have others that we can reach for. But the two main ones are aspirin and Plavix. And aspirin, of course, is an over-the-counter drug that is universally available. And Plavix is something that you have to get with a prescription. And basically, platelets are these incredibly sticky, very small cells that are all over your bloodstream. In a cubic millimeter of blood, which is, you know, a volume the size of, I don't know, a sesame seed or something like that, there are probably 250,000 platelets in that volume of blood. So they are everywhere. And they're very sticky, and they'll grab onto anything, whether it's a loose piece of fat or a little exposed piece of stainless steel in the bloodstream or anything like that. And so what these antiplatelet drugs do is they make those sticky platelets less sticky. And again, this is extremely important in heart attack, and also it's equally important in the protection of stents after a stent goes in. So when Dr. Bilazarian sees a patient who has a critical narrowing in one of the coronary arteries or fuel lines feeding the heart muscle, and he puts in a stent to essentially scaffold open or brace open that artery, for a while there's going to be exposed stainless steel or some sort of foreign material next to the blood supply in the wall of the artery. And it depends a little on the stent, but we always have to have someone take a combination of aspirin and Plavix. That's two different simultaneous antiplatelet agents for either a month with certain kinds of stents or even sometimes beyond a year. And so it's absolutely crucial that when your doctor and your cardiologist tells you that you need to be on aspirin and Plavix to protect the stent, you have to take it as if you didn't take it, a heart attack, another clot could form inside the stent. So it's tremendously important. Seth, I imagine you see this more than you care to remember, really, about all of these stent thromboses that can happen.
So stent thrombosis, exactly as you said, is just clotting inside of a stent, and it seems to happen. The vast majority, some people have said 70 to 90% of all the stent clots that occur are in the setting of people who fail to take their aspirin and Plavix. Certainly the Plavix being the most important. So you're absolutely right. I agree with you. Let me just say, if I could take a moment just to review what you said, just to make sure I'm understanding. So you talked about these three drugs, but really two categories of drugs, the aspirin and Plavix being antiplatelet, and then the Coumadin or warfarin being the protein-based kind of way to treat them. And I think that your focus has mostly been that the aspirin and Plavix have really been for the artery-type problems, and that the Coumadin or warfarin medicine is more for non-artery problems like the atrial fibrillation that can form a clot inside the heart chamber, or clots that form in the vein, or a pulmonary embolism kind of patient, or a patient who has a heart valve. So that they have different modes of action, but we actually use them for different types of patients as well.
That's right. And we also know this, that again, it's the sort of idea that all of these medicines do, in a loose sense, do the same thing, but that they work specifically in different areas. And exactly. And so we know from patients, for instance, who are born without a particular clotting protein, that if they have bleeding complications, they tend to happen in a particular type of thing, like there may be bleeding inside of a muscle, or bleeding at the gums or something like that. And then with other kinds of clotting disorders that people are born with, that you might get an entirely different kind of bleeding. So really, there are different parts of the whole clotting system working in different tissues.
Right. And
what we're doing is, when we say, oh, that person had a pulmonary embolism, that must have arisen in a vein, therefore we give Coumadin, because that is really an approach targeted towards veins. Whereas in the line of work of an interventional cardiologist in the coronary arteries, it's more of a platelet-driven thing. And you'd think, you'd think in some ways that Coumadin is, Coumadin I think has the reputation somewhat accurately as being a stronger blood thinner overall, right? I mean, if you take Coumadin, you're probably more likely to have bleeding difficulties than if you were to be on aspirin or Plavix. But really, if you're having a heart attack, one aspirin does a world of good more than what the Coumadin would do, and that's really because you're targeting the right medicine to the right mechanism of disease. So just to get a little bit more into aspirin, and we can start with aspirin. Aspirin is, of course, as old as the hills. It's been around forever, and it comes from the willow tree. And what some people say that if it were just coming out on the market now, it might actually be a prescription drug, because it has some significant side effects, and people can get ulcers sometimes from it. But it is out there, and it's in your medicine cabinet and in the pharmacy over the counter. It is an antiplatelet, and it works differently from the other one, Plavix. And it's also an anti-inflammatory. So people have taken it for headache because of its pain-reducing abilities. They've taken it for their sore joints because of it as an anti-inflammatory. Of course, it's essentially the original NSAID, or non-steroidal anti-inflammatory. So Advil and Naproxen and all those drugs are basically cousins of aspirin, which was on the scene first. But the thing is that in being not only an antiplatelet but an anti-inflammatory, it has this tendency to erode the lining of the stomach and make the mucus protection on the inside of the stomach thinner and a little bit easier to break through. And so if people are taking a lot of aspirin for a long time, they can end up having erosions in their stomach and develop ulcers. And this can be a reason definitely to stop the aspirin if we have the luxury of doing so and they didn't just get a stent a couple of months ago or something like that. But that it's also important to know that sometimes when people do get stomach bleeding problems on aspirin, that you can often move over to Plavix for your antiplatelet therapy without having that stomach-related problem. So we often will be choosing aspirin or Plavix in a given situation, and if ulcers are an issue, then we often may choose Plavix over aspirin. The question of which one is right for you is, of course, really a question for your physician. Plavix is something that you would need a prescription for anyway, and so really this is something that you would communicate with your doctor about. The other thing is that if you have to be on an antiplatelet agent for whatever reason, like coronary artery disease, that cost can be an issue as well. Plavix is significantly more expensive than aspirin. Plavix can be, for some people on some drug plans, as much as $100 a month. And so in choosing, we're also trying to not break the bank, empty the wallet of the patient. So a lot of times we will choose aspirin first unless there's a significant downside that we expect in terms of stomach bleeding or those kinds of complications. And I guess the question also is, well, which one works better anyway, aspirin or Plavix? Of course, with stents going in and things like that, you have to be on both. But if you have to choose one or the other, there are a lot of areas where this has been explored. I guess I would say generally that aspirin and Plavix are generally considered to work the same in terms of preventing clots in various places. For instance, if you have atrial fibrillation and for some reason you can't take Coumadin, going on aspirin or Plavix is generally considered a equal risk kind of proposition. And then the follow-up question I think is often, well, what if you took both? Is that twice as good? Does that mean that that you would have half the events or something like that? And the answer tends to be almost independent of what disease is looked at, that when you add aspirin and Plavix together, even though they work with similar mechanisms, you get having the two of them together reduces clotting marginally more than one alone, but whether that is worth it and worth the expense and whatever the extra bleeding risk, because there would be extra bleeding risk as well, is sort of a decision for the physician. So just in the last week, I believe, the New England Journal of Medicine came out with, published a paper about aspirin versus aspirin and Plavix in atrial fibrillation. Again, in atrial fibrillation, clots can form in the heart, and we often start people on warfarin, but in the people who are not candidates for warfarin, we are often left with either aspirin or Plavix or both. And what we found is that, just like what I was saying, aspirin and Plavix together shave about 1% per year off of the risk of having a stroke, but the combination of the two does produce a little more bleeding, and it's also not nearly the stroke reduction of warfarin itself. In fact, it's sort of halfway between aspirin and warfarin.
One thing I would ask you if you could help us address is a common question that patients ask about aspirin. Two questions is, what's the right dose? And the other question would be, you've covered really very well and helped us understand how these drugs might be used for people with disease. Is there a role for patients or any particular subset of patients who don't have disease yet? What would you recommend for aspirin in those patients?
Absolutely. So addressing the question of dose first, doses ranging from 75 milligrams, which seems to be the low-dose aspirin in Europe, or 81 milligrams, which is a low-dose aspirin in America, or 325, which is a full-dose aspirin, or even sometimes 500 milligrams, then in terms of antiplatelet effect, they all are basically the same. And so for daily maintenance aspirin, we usually have people take low dose. Having said that, there are times when we feel strongly about being on a full-dose aspirin, and one of those is heart attack. And I think the issue there is twofold. First of all, the studies were all done on full-dose aspirin, and so that's what we know works. And secondly, if you're taking a larger number of milligrams and time is of the essence, and then this clot is forming by the minute, taking more aspirin probably means that your blood levels will get to where they need to get sooner. And so taking a full-dose aspirin when you roll into the ER with a heart attack is really the way to go. But once you have your stent, you may take full-dose aspirin for a couple of weeks and then drop down to 81 milligrams after that. Is that sort of what you do?
Yes, I think so.
Yeah.
And from a stenting standpoint, I think we've adopted the approach, as you said, for a week or month. But afterwards, we think that there's no added benefit of being on anything over aspirin 81 if you're also on Plavix. But there is excess bleeding at higher dose. So it's no benefit but all risk. So after a month, we generally switch.
That's right. Yeah, that makes sense. And then the other question you had to do with who takes aspirin for day-to-day preventive,
Is there a role for people without
events.
disease? Who would you recommend it for? Would you recommend it for your dad, your grandfather, uncles?
Right.
We definitely recommend it after a heart attack. But how about people who haven't not yet had a heart attack?
Right, that's true. So what we call secondary prevention, which is basically after events, that's kind of a no-brainer. But then in primary prevention beforehand, we generally say that as people get a little older, so as they get to be 50, 55, 65, they might develop a risk factor for heart attack, like hypertension or high cholesterol. Then we start thinking about adding a low-dose aspirin every day. In terms of, you could ask, well, why not just put every 25-year-old in the country on baby aspirin, and wouldn't that prevent more heart attacks? Well, it might, but it also would mean a lot more stomach ulcers. And when those studies have been done, they've generally arrived at the conclusion that really it isn't the way to go.
So it's the way to go for older patients?
For older patients or patients with risk factors for coronary disease.
So you would recommend it for anybody without even risk factors at age 50, or what is your general?
Yeah, I would say that's what I would do. Is that kind of what you're...
Well, the only thing that I didn't know, and I was interested in your view, is that the data seems to suggest that it's strongly recommended for men over 50, but it seems to be less clear for women. And I'm troubled by what to say about that. I'm certainly not discriminating against women by not giving it to them, but there's a large data set, actually generated by the folks at the Brigham and Women's Hospital called the Women's Health Initiative, which has repeatedly shown that if you give women without a lot of risk factors, just all women over 50, a baby aspirin a day, there does not seem to be the reduction of stroke and heart attacks that we see in men. So I'm not really sure, and I didn't know if you had thoughts on that.
Well, because it's unclear where exactly to go with that information, I usually tend to treat them roughly the same in terms of if I think that patients have high cholesterol and hypertension, things like that, I usually will end up giving it. But I realize that the evidence is not as compelling. With the limited time we have left, I wanted to get into Coumadin, which is really, in some ways, a pretty complicated medicine. I guess I wanted to nail home a couple of points about Coumadin. For one, this is a medicine that when you're building clotting proteins, or many of the clotting proteins in your body, you are taking in a vitamin called vitamin K in your diet. It's in green leafy vegetables. That vitamin is going down into your esophagus, stomach, going down into your intestines, and then the bacteria that live naturally in your gut actually get to work on it, finalize the version of vitamin K, and then it gets turned into clotting proteins, and then the liver produces those clotting proteins and makes and you have thicker blood because of it. What happens is you have to know there's a massive delay in all of that. So when someone is taking Coumadin for their deep vein thrombosis or a clot in their heart or something like that, they are essentially taking an sort of like anti-vitamin K, an opposite of whatever your dietary intake is. And so it means that that pill that you take on Monday probably is not going to start to thin your blood until something like Wednesday or Thursday or something like that. So you have to know that this is not is a medicine that works in a very unusual way and in a very delayed way. And so it takes a while for the blood thinness, or what we call the INR, which is a number that describes how thin the blood has become. It takes a while for that to get going, and that changes can be made alternating doses, Monday, Wednesday, Friday this dose, Tuesday, Thursday that dose, and it will all sort of smooth out over time because the delay in the mechanism is so gradual. The important thing, I think, to know about warfarin is that it's important to get your blood checked for it. That lab is, again, called INR. And what will happen is you work with your physician, and he or she will tell you when to come in for your next test. And it's extremely important to get that checked, because if it gets too high, you're at an increased risk of bleeding. And if it gets too low, then you're not getting the benefit out of the medicine that was hoped for. So there's a lot to talk about with warfarin, and it's a great thing to talk about with your physician so you understand it well. I think that's about it for today.
Well, thank you, Dr. Conway. What a wonderful and fantastic review of the topic of blood thinners, as you call them, and we talked to our patients about it. And you did a beautiful job covering some of the basic issues about aspirin, Plavix, and Coumadin. It sounds like we shortchanged ourselves on Coumadin, and maybe we'll come back for another edition of Coumadin next time. But thank you again for that great review, and I'd like to sign off now. I'm Dr. Seth Bilazarian, signing off another edition of Matters of the Heart. Thank you for joining us, and we look forward to seeing you next time. Good night.